So how many people here have ever been a member of a community advisory board? How many people have ever attended a meeting of a community advisory board? Okay. And so what did you think about it? Or was that the CTSI Community Advisory Board or something else?
Something else.
And?
It was interesting to hear about the priorities of the community versus what, you know, we thought would have been interesting to study or would have been important to highlight. Just some of the different things that get picked up and prioritized over, you know, so I think it provided a different perspective than what we had intended going in.
Well, that's good.
Yeah.
Yeah. Any other comments?
I want to make a disclaimer. I come at this from the HIV world, and as you'll see in the history, I think HIV advocates figured prominently in, you know, where community advisory boards are today. I was an intern in 1980 in San Francisco before we knew AIDS was AIDS, and then, you know, sort of until I came to West Virginia, that's really all I did. On both sides, I was in the pharmaceutical industry. I ran a big HIV program in Newark. So, you know, you got to understand my bias, but I've never given a talk on this. And I was shocked at how little there was out there. It's really quite amazing. So it's going to be light on references. I thought I'd talk a little bit about the history and then really about some of the stuff, you know, how do you define community? What is the purpose of a CAB? And I think there can be sort of different, you know, objectives, and I think you have to think about that. And then just some of the nuts and bolts, processes, member recruitment and retention, which isn't there, support, and then a few conclusions. But, you know, there's nothing worse. I wish we had food and, you know, please talk and disagree, because I think this is an area where it is really nascent, as you'll see. I mean, just historically, we're talking sort of the last 80 years. And in the 30s, there were the Tuskegee syphilis experiments that I'll talk about. Of course, nobody knew what went on until the 70s, so I was actually in college. It's unbelievable. There were the atrocities committed in Nazi concentration camps. And, you know, really, I think that historically, as these things all came to light, it became clear that it was incredibly important to really protect participant rights and to have community members involved. And most of you know this, but obviously there were horrendous war crimes. Informed consent was not existent. And as a result of the Nuremberg trials, the Nuremberg Code in 1947 really sort of said people have to consent and know what they're consenting to. You have to have qualified researchers and appropriate research designs. You have to minimize risk to subjects, and participants have to be free to stop at any time. This is a picture of the Nuremberg trials. There was actually one, not shown there, one woman physician who was tried, and all the men were hanged, and she was not. She should have been. But it's very, has anybody read The Lilac Girls? It's a historical fiction, and it really sort of follows three women who actually were, you know, real life women. One was this Nazi doctor and her traumatic past. One was a socialite from New York City, and one was an individual who was a Polish woman who was in the Nazi camp. And these were, Ravensbrück was the only Nazi concentration camp that focused on women. And that was the camp, and as an infectious disease person, I just, you know, shiver every time I say this, where they went in and they put different organisms in the bone. They put tetanus, they put, you know, anaerobes, and then some of them they would give sulfa and some not. So as you can imagine, even those that survived, and many did not, you know, they had horribly crippling bone malformations, and many of them had a chronic osteomyelitis infection of the bone. And so the socialite New York actually raised money, and they came to America and had reconstructive surgery and so forth. And in the concentration camp, they had been called bunnies because they had to hop. Usually they just did one leg. It was unbelievable. But you just read that and just just the horror of what went on. You know, thank God this came to light. So in 1964, there was the Declaration of Helsinki, and you guys know this from the city, but it really was amazing that it then took, 17 more years to really sort of come up with a worldwide declaration that really has been the basis of much of the subjects protection. But that's not the end of the story, because the New York Times in, I think it was 1972, broke the fact that in the 30s, Black, mostly sharecroppers in Alabama, were recruited and were followed, knowingly having syphilis. Now remember, penicillin became known to be an effective therapy for syphilis in the 40s. These folks were followed for 40 years. When you have tertiary syphilis, you really get involvement of the spirochete in the vessels, and you get aneurysms that burst. You get CNS syphilis. I mean, it's just unthinkable. This went on in this country and was not brought to light until I was almost in college. I mean, that's just, and so as a result of that, it led to the National Research Act, and a commission subsequently was formed, which led to the Belmont Report. And really, the Belmont Report is where human subjects protection really took off, and it really had principles that you had to have respect for persons, that there had to be beneficence, there had to be a clear, what was the risk benefit, and that there had to be justice. You couldn't just go into poor sharecroppers and recruit them in a trial. And yet, despite that, you still didn't have community advisory boards. That's 1979. I mean, I'm almost out of medical school now. And the respect for persons really included the fact that you had to, make sure that people knew what they were signing up for, that they had to have their privacy and confidentiality protected. The beneficence was that vulnerable populations, particularly children, pregnant women, and prisoners, and interestingly, recently, with the common rule, they had changed the definition of vulnerable populations. And I think vulnerable populations sometimes was really individuals who were not enrolled in trials, particularly pregnant women and prisoners, because of this issue, and they've taken pregnant women out. So what happens? You have no studies in pregnant women, except for those drugs exclusively for diseases or conditions of pregnancy. And so then pregnant women are exposed to a lot of drugs and nobody has any idea. And you have the thalidomide tragedies there. You have to maximize benefit risk and balance the risks and benefits of the individual to the society. And then justice, as I mentioned, you can't pick on one group, and really selection has to be fair and widespread. And so then after the Belmont Report, people started to talk about, well, what may be fair and ethical to a researcher may not always seem so to the community. That the community really can best provide the potential subject's point of view, certainly not somebody sitting in the ivory tower. That input on whether a question has value to the community is probably best adjudicated by the community. And then again, the informed consent. In the HIV field right now, we have 30-page consents. And you really have to wonder, is it readable and understandable, or are people just signing their name because they don't want to read 30 pages? That's what I would do. Oops. So what happened is that tags then subsequently evolved in the 80s. And I think that there was, a couple of things. Number one, the social scientists started to say, you have to have participatory action research, that if you're really going to change effectiveness, you really have to have a community participate. And that was really the origin of community participatory research that we have today. We really came from social science. In the late 80s, early 90s, you had the HIV epidemic, and HIV advocates, we would not be where we are today without the HIV advocates. And they really developed the community advisory boards that became watchdogs. They said, how can you have clinical trials? And clinical trials were set up with placebo arms, right? So you got somebody with end-stage AIDS. Everybody knows that individual is going to die from 6 weeks to 3 months. And NIH was running trials with placebo arms. These guys were absolutely right. And what's more, I remember my first patient I had on the first effective cocktail that had Crixavan. And this guy was, I think he was 6'1" and he was 90 pounds. I mean, man, he was going to die any day. And we got him on the Crix trial, and he started to eat, in a week. I remember saying to myself, my God, this is a new day. And so, meanwhile, we're doing placebo arms, and if it hadn't been for the organization of the AIDS community, I think we would not have moved so quickly. And I'll tell you, this is, you'd think that we would learn from that in the recent Ebola epidemic a couple years ago. So there was a big fight again, because with some of the monoclonal antibodies, they wanted to have a placebo arm. And even with the vaccine trials, they wanted a placebo arm. And everybody said, this is nuts. You can't do this. NIH was really going to do this. It's interesting. NIH today says, well, we were right. We've had this discussion in NID. We were right. Because if you look at the mortality of individuals who were brought to this country, nobody died if they got here because of the supportive care. And if you even look when supportive care got better in Western Africa, the mortality fell to 30%. I would suggest that's why you have, you might have thought that, but if it's 30%, then you would go on, and at that point, your original trial design might not have worked anyway. So it really still, I think, without community advisory boards as watchdogs, I think we keep making the same mistake because we just want the great science. It's interesting, the Ebola vaccine trial they did was a ring trial. So they didn't separate, the original design was you have communities who get placebo vaccine versus the real vaccine. The endpoint was incident, and everybody howled and said, this is unethical. So what they did is they had a community that had a high rate of Ebola, and they vaccinated everybody around these communities. So they didn't have control and placebo. And then they looked as you went out in a circle from that community, did the incidence decrease? And of course it did. And probably with that trial design, it's estimated that 60,000 people actually were probably saved from getting Ebola. That vaccine is now in trial, and I think it looks pretty good. But that just goes to show you how important community input and ethical watchdogs are even today. And then, in the early 21st century, there was a lot about not only making sure that communities were not exploited, but, a little bit of the community participatory research that, your community really need to have, if you were having a broad community group, and I'll talk about different community advisory boards, to really help with research agenda setting, and also to facilitate effective result dissemination. I think a legitimate criticism of community of Ivy Tower research is that folks go in, they do great trials, they write the New England Journal of Medicine paper, and the community is never informed what actually went on in translatable language, and also what are the implications for that community, which I think is a mistake that we also make today. And I think CABs have gone a long way to facilitate being able to translate back the results. So, the first thing, there are all different kinds of community advisory boards. You can have a broad community model, and you really need to represent a cross-section of the community. And I'll just take the example of our CTSI Community Advisory Board that we started this year. And, we really want to represent the community in West Virginia, which is pretty broad. I think it's a work in progress, but you really have to have, we have a member, an African-American member who's a member of the faith community. We have somebody who's in municipal government. We have some folks who are in recovery. I think there are others that need to be there. I would suggest sort of somebody who in the mining industry, but you really got to look and say, what is the cross section you want? And I would contrast that to I have population specific, and what I mean by that is a very specific advisory board. An example of that would be in Newark for our HIV trials. We had a CAB, and the requirements there are that everybody had to be HIV infected. And they really, we discussed, should there be people that aren't HIV infected on there? CAB said no, you know, there's stigma, we don't want that. But then within that, you really have to make sure that you have the constituents. 80% of our population was African American, but 15% was Latino. So we made sure we had Latino and African American. 40% of the individuals with HIV in Newark were women. We really made sure we had women representation. And that is really quite different, I think, than the broader model. So if you're running a series of trials on rural oral health, you know, I think that you really would think about an advisory board different than if you're running a CTSI CAB. And one of the questions I have, it's premature probably to ask it, and certainly to act on it, but does the CTSI CAB, can they serve as a springboard for disease-specific or area-specific studies? And ultimately, I would think that it would be a resource that should be able to do that, but I think it's not ready for prime time yet. I'm just droning on. Doesn't anybody have any disagreements or questions or comments or? No? I've never heard this group be quiet. I think the next thing you have to do is define the purpose. And again, I think that these are highly variable. This is actually one of the pieces of the papers I did find. They didn't see the date down there. It's pretty dated, but it was, again, HIV/AIDS, 267 CAB members were surveyed. And their, you know, sort of what they felt was their purpose was communicating community preferences about research and research agendas, educating community about HIV. One might not have thought that that was a CAB you know, function, but that's what these folks thought. Recruiting study participants and evaluating study-specific materials. Absent from that research, from that survey, was result dissemination. And I would say, just to go a point further, the Division of AIDS used to have 5 trial networks. There was vaccines, AIDS treatment, prevention, microbicides, and children. They've narrowed that now to 4, but each of those had to have an organization-wide CAB, and you had to have a CAB member on every study protocol. And I can tell you, I was a study chair for a 2,000-person NIH trial in the prevention network, and Wahida was my CAB person. She came to all our meetings, and she really made, you know, the protocol better. I mean, we put something in, we think, and she said, "You guys are full of you know what, you know, you can't do this." And I got to tell you, it's I think we need, at least in West Virginia, and I've not sort of been a protocol chair in that sort of setting, but I think we could work much more effectively with community and probably have, you know, more successful studies if we did that. My vision is, as we really sort of develop a robust CTSI CAB, is to be able to do that. Okay. I think we covered this before. You know, these are important things that the CAB could do, and not everybody in the CAB wants to do every single one. My goal for our CAB this year is to inform the CTSI research agenda. And I think, you know, this takes time, as I'll say, as CAB members get comfortable, you know, with working with investigators. You know, it really is an evolutionary process that does get deeper with time. I think one thing, and though literature doesn't say this, you have to really, as I said, have an ongoing relationship, and you have to have a consistency from staff and investigators. And in fact, I think that there's a point of contact that's preferably one or two individuals. But, you know, community members are really busy. It's not their problem to figure out when's a good time to meet, where to meet, order the lunch, and though they should inform the agenda, somebody's really got to print the agendas, take the minutes. Actually, in our cabin Newark, we had a secretary who took the minutes, but one of our folks worked with that individual, you know, and put them on Word and so forth. So, I mean, you really have to, the group sponsoring the cab really has to have a commitment to doing it. And it's not something you could start and, you know, everybody's busy, and then you have a couple of cab meetings and folks don't show up, and, you know, you really have to keep at it. It does not happen overnight. I loved our Newark cab because, you know, we would meet late afternoon, and we would have actually, it was dinner. We didn't call it dinner, but it was dinner for these guys. And it was really interesting because they became irritated when, you know, people wouldn't show up. So the cab members said, we are going to have rules in our bylaws that you have to attend. I think they met every other month, so it would have been 6 meetings a year, and you could only miss 2 or you're booted out of the cab. And it improved attendance. But that's the sort of empowerment after you sort of, you know, work for a while, and if you get good leadership in a cab, that's nothing that any of us sitting around the table say, oh, you can't come and, you know, if you miss 2 times. You never say that. But that really, I think, really is a sign of health that folks, the cab members are really making their own rules, what they want to do, and that's what you really want. Recruitment's a hard one, as we've seen, and it really, I think, depends on the objectives of the cab. I think I mentioned this earlier that, you know, we were looking very broadly in West Virginia. In Newark, we were much more narrow. I think persons have to be interested in research and willing to learn about research if they're new to the area. I don't think anybody needs any specific level of education. I think some of our best cab members in Newark were individuals with a grade school education, so that wasn't there. But what is absolutely clear is if you are organizing and supporting the cab, you have to provide training, and we'll talk about that in a minute. You need to think about, are there key organizations that should be represented, though you have to watch out for conflicts of interest. Not infrequently it comes up that if you have a funder who's also very active in the community, they want to be in the community advisory board, and that is a source of conflict. And we actually had this issue with our cab, and it can really inhibit some of the discussion that goes on. So you have to be very careful about that. And again, it has to be representative of the community that you're seeking to, you know, represent and define, and that can be different things.
Sally,
Yeah.
you just made me think about something about industry representatives that I've not thought about before, haven't even considered. It just really makes me wonder. I mean, you know, is it appropriate to have pharmaceutical company representatives or dental supply representatives, or would that, boy, I don't know, that really just, you're just bringing up the issue, makes me think.
Well, good. That's what, I mean, you know, so we would, in Newark, we would bring every trial we were going to do. Believe me, we had a lot of HIV trials, treatment trials, so we would bring every one of them to the cab. And I got to tell you, you know, well, a couple, I'll tell you about that in a minute, but the industry thing, obviously industry always wanted to supply the meals and stuff, and we had none of that. I mean, you know, sort of, we actually sort of took it out of our budget of the clinic. And while we could have industry speakers, and the cab members liked that because they liked to hear what was coming on, they were not cab members and they could only be invited to speak and they could not vote. Now that's, you know, there are no rights and wrongs, by the way. I mean, I just think it brings you up and you need to think what you're trying to do. Yeah, so.
That approach seems very sensible to invite them to share information, but, you know, to keep some distance in terms of, you know, potential conflict of interest or appearance of conflict of interest.
Yeah. I mean, the HIV advocates are great, and I mean, it's a legacy. So, you know, you'd bring these guys and they would get into discussions that, you know, why are you charging so much? Well, the 340B pharmacy isn't that. I mean, the CAB members are really knowledgeable. And if these guys wanted to come and speak, I said, well, you're going to get asked some hard questions, so just be ready. And I think that was actually a good interchange. You know, you always have to think how members will be invited. I mean, invariably, you just start as the organization supporting it, whether it was the Newark HIV Center or the CTSI, and you invite members. But ultimately, as you get started, and hopefully we'll be transitioning to this, then you want your members to identify other members and to ask them. The only thing you have to be careful of is that you don't get clicks. And so you need to be very, very mindful of that as well. And then it is really, CAB recruitment and retention is an ongoing process. Things change in people's lives. They don't have the time, and it does take the time. So don't think that you go out and recruit, you know, 10 people and you're done. You're not done. I think that it is a consistent thing. And, you know, we had a discussion in Newark about requirements for membership and so forth, and the CAB determined that, which I think gets me to my, let me go to the processes and I'll go back. It's really important that you have bylaws. And, you know, the tip is every CAB, most reasonable CABs have bylaws. There's lots of copies you can get. Actually, we still, I think, the Newark bylaws for the CTSI CAB, but there are others. And that's not, you know, you don't sort of do that and only use those bylaws, but it's at least to start. CAB members will say, well, why did they do this? This is stupid. Get rid of that, or they didn't think about this. So I would say at least you have, you know, bylaws are one of those, you know, boring, tedious things. So if you can start with the document, it's much easier to get there. You know, how are things going to be decided? What's a quorum? Who's a voting member? By the way, in Newark, all of the I would actually go to most of them when we started, but the investigators could not vote. It was just the members. So the frequency of meetings, it just really depends. You know, I think it's hard to do very many meetings. It's even hard every month, and we were right on the main bus line in Newark. So you need to sort of think about that. Just back to this, again, you know, I think it's unfair to bring people in to a community advisory board for a research organization and not have some training. You know, there's a content area literacy. The example in HIV would be, you know, so what are the current research questions, you know, HIV 101, what are we trying to do? So when folks look at a protocol, they understand. We had a session, I had a set of slides on how to read a clinical trial protocol because they were reviewing every one. I think, you know, what we're looking at for our CTSI CAB, at least at present, and I hope it will evolve, is to really help us set the research agenda. So you have to really have a summary of past research and have context for folks. You just can't expect folks to comment. And then, you know, there are many CABs that actually review, if they don't review and vote on whether to do a trial or not, they look at the informed consent and requirements. And if they're going to do that, then there has to be some training on what's expected from informed consent, what elements have to be there, and so forth. So those just are some of the things that's not complete. I think you need to make it attractive for the training. We used to try to combine the training and the meeting, so it would be an hour of training, an hour of meeting, and, you know, good food in between, you know, to make it worth folks' while, because they are giving of their time. The other thing is, you know, on World AIDS Day, We would always have sort of a cab recognition event, everybody that was a member. I mean, we had some really funny things, but, you know, we always got them something. You have to acknowledge their time and their commitment. And I think it's something we need to think about at CTSI, because it really is just, you know, they're volunteers. They don't have to do this. The logistics, you know, I think you also, the folks that are setting it up, we talked about most of these things, but also the CAB has to decide how formal is it. Robert's Rules of Order, the hilarious thing I loved about Newark, because I thought it would be, you know, Newark, inner city Newark. I thought we just sort of, does everybody agree or not? The CAB really got off on having an orderly meeting. We had to buy copies of Robert's Rules of Order, and they really ran it. It was great. I didn't expect that, but you know what? If that's the way they want to run it, it's their board, and you just support that. So, you know, that's something to sort of discuss after you get going. And as you can see, you know, you start and then you hone down, and obviously things get more organized, get more clear, get more ordered. And I was just shocked in Newark. It's one of the most orderly cabs I ever had. We had this guy who would one of our chairs, and we changed chairs every 2 years, and they voted, but that's something you decided in the bylaws. This guy who was one of the best chairs we ever had had like been in prison for 20 years. I don't know what he had done. I never asked, but something bad. He was great. He was really great. And then, you know, I've said this before, I think that over time, the agenda and the leadership are developed by the members. I think there's a gradual transition of ownership and responsibility, understanding that, you know, a lot of the logistics and the food ordering and all that stuff really resides here. That's not their problem, but the content and the decision-making is really there. And be prepared for CAB spinoffs. You know, you can't start this and not go where it goes. So when we started with prevention trials, and this was great because we bring it. Now all these folks are HIV infected. The prison chair said, he said, you know, Dr. Hodder, you need people that are HIV negative. We need an HIV negative CAB as well, because we're making decisions, but what do we care if we prevent it? I mean, it was, so that was true. We were a big center for treatment and prevention of women with AIDS. Women said, we need our own group that we can talk about stuff. So we had the master CAB that then had all these groups, and then we had actually 2 other groups, the prevention group. Some of the HIV infected guys wanted to be in that, and that was fine with the HIV uninfected guys. And you can see how this was starting to break down stigma. All at once, HIV infected folks, it was like, well, I'm going to go to that CAB because they do not understand all the stuff about HIV. I mean, it was really pretty interesting, and I'd never sort of seen CAB as, you know, in a microcosm breaking down stigma, but I think that's exactly what it did. And then the women's group, but I have to tell you, so there's HPTN 064, the 2000 women study. So we were coming to the end, and we had talked about the importance of not doing helicopter research of going back. So at the women's CAB meeting, there was the national protocol chair, we had 5 other sites. And so the Newark group, they said, we need to do, you know, a televised webinar about the results. It has to be the same week you're presenting them at the retrovirus meeting. And I thought, oh my God, you know, it was great. That's exactly what we did. And then for the implications for Newark, we had a panel of civic leaders that included Cory Booker, who was the mayor of Newark at that time, the Department of person, a participant, an HIV infected person who was on the CAB, law enforcement, and we really talked, you know, about the fact that women, intimate partner violence turned out to be a big issue, particularly with HIV acquisition of women that came out of this study. You know, even though women, only 4% said they were commercial sex workers, 37% said they really had to put up with whatever he wanted. because they needed a roof over their head, they needed food and all this stuff. And we started to talk about, you know, the issues and the injustice about women, you know, what they had to do just to exist or so their children had food. It was actually really great. And that all, I don't think would have happened had we hadn't have evolution, who was really thinking very deeply about how to get these data to make a difference, which is what we really, really want. Oh yeah, conclusions, but you can read. So I mean, that's, oh, I guess it wasn't that short. There's no, it's not rocket science. There are not a bunch of scholarly papers telling you how to do it. I think perhaps we ought to write one after reviewing the literature that was non-existent. So what are your thoughts, questions? I mean, disagree. I'm not saying I'm right. I'm just basing this on my experience.
We're going to unmute all the participants on Zoom too, so if you have any questions from our partner sites or in the community, let us know.
I keep people involved.
Yeah, that
It's
is,
always been my biggest.
yeah.
I mean, everybody, like you said, everybody's life is busy and they're doing this on their own time. But it is difficult when you keep replacing people every year and get to the point, or sometimes you get to the point where you're just repeating yourself because you've got all these new members all the time. And I just feel like I'm spinning my wheels sometimes.
No, I think that's really true. I think HIV, there is a commitment there and a legacy of advocacy that makes it easier. But I would say that I think the bottom line is that people have to feel it's worth their while. And they have to get out something out of it too. And I mean, that nice food is one thing, but I think they have to see substantive input and, you know, sort of an honest request for their advice and then following their advice. And you know, we actually, the Newark one, we had really good discussions. I mean, the investigators would push back in a respectful manner, but we had a good discussion. I would say almost always, well, we did almost always, if the CAB said you can't do this trial, we didn't do that trial, even if we thought it was an important trial. Interestingly, as it evolved, you know, as the cure research agenda came in, but at the time I was leaving Newark, you know, these trials were taking people off antiretrovirals for a month and, you know, doing multiple colonoscopies and all this stuff. And like, I would present these things, I would say, you know, are you sure? Do you think this is appropriate? I really have my doubts. You know, we presented everything that the ACTG, the AIDS Clinical Trials Group, wanted to do. The investigator would give their, you know, sort of assessment. I particularly did not like that trial. And they said, Dr. Hodder, Newark doesn't do cure trials. We'll never have a trial. I mean, they became actually more enthusiastic than I did. And if they approved it, you know, we approved it. But so I think that that's true. I think that also you have to have good community leadership that really is willing to call up people, and we have to do that. And I think that's where we are right now with the CTSI one. You know, we really, I don't think, and we've only had 2 meetings, so, you know, it's early, but you really have to develop some leadership that will then go out and, you know, seek and say, you know, we really need to meet, we're doing this. And then you have to make it easy for folks. It can't be at like 6 o'clock in the morning. And I mean, everybody does that, but so there's no easy answer. And I think recognition is a big thing.
Yeah, when you mentioned that, that's interesting. I've not really thought about that.
Yeah.
I've wondered whether WVU could do something that would serve a number of research projects, because each of us, I think, are trying to establish community advisory boards, and it is a lot of work. And you know, could there be a board that could serve a number of different functions? You know, particularly if you look at health-related research in general, because we have, you know, there's the CTSI have, I believe there is a separate one for the Prevention Research Center. You know, we have these, and we're going to the communities and looking sometimes for the same people. Are we asking too much of them? And, you know, could there be a more, at least in some instances, a general kind of board? In our project, our Center for Oral Health Research in Appalachia, we are partners with Pittsburgh, University of Pittsburgh. They have at Pittsburgh a community research advisory board, a CRAB, they call it. And we were starting a new phase of our project. We actually had to apply to them to be considered for them to review our protocol. And then we went and presented it, and they made a number of helpful suggestions, actually very helpful, sometimes challenging, which I think was just great. But that's like an entity, their CRAB is set up at the University of Pittsburgh. I think they devote some institutional resources to making it happen. Made me wonder, I mean, that was, you know, is that a model or something like that that you've heard about that we should consider at WVU?
Yeah, well, to tell you the truth, so that is sort of been my thinking with the CTSI Community Advisory Board. Now, and that, I mean, the history is the CTSI Community Advisory Board and the PRC Community Advisory Board were one and the same. And it was and that actually made sense. I mean, Jerry Dino, you know, is the chair of the Community Engagement and Outreach. But their focus was more narrow, and you know, some of the considerations, at least in my history, about who should be members and who should be not, I think there was a different, you know, feeling there, and that's fine. There's no right and wrong. And also, I think that the CTSI is a more broad agenda. So our view was that we really needed to develop a board. And as we've increased clinical trials, ultimately what I would like to do is to take it, you can't take all the trials to that board, but you know, for particular trials, or if there's a group that really would like to review the list, to use that group. And I would never impose that on, I mean, I think an investigator, you know, needs to do what they want to do and what's best for their project. But I you know, it's my thinking that if there are investigators that think it would be worthwhile or want to use that, or have, you know, some members of a community advisory board, but you know, it's a pretty heavy lift to get a group that meets regularly, that you can retain. So if we can combine our efforts, we are more than happy to do that. And that was part of the genesis, you know, the impulse to really sort of start the CTSI Community Advisory Board, because I think we're really, you know, going to be doing that. And I'll tell you, one of the things that we did at our first meeting is really discuss this deep brain stimulation study that we have, that was funded at the first time. We hadn't started it. And, you know, I'm always shocked about, you know, the community view. They thought it was great. I mean, and they said, you know, we need to try answers and so forth. And you know, I think they're really sort of hearing what is out there, and sometimes not what you think it's going to be. So, you know, I guess my answer is, you know, if you feel that that can be useful to you, or you in any way want to use that, I'm absolutely open, because this is, I think, should be a resource. And, you know, if it's like the HIV crew that then breaks off to more specialty groups after they get a rapport, that's great. Yeah.
One thing to keep in mind is if you're looking at a specific county or a clinic, you're partnering with a clinic, some of these organizations are required to have advisory boards made up of their patients, things like that. So if you know you're going to work with a specific clinic, they might already have a board set up that you could then partner with them, so you're not tapping in, you're getting to that problem, recruiting people and things like that. So that's something else to keep in mind on a smaller scale, is that there are other organizations that are required to do it.
Previously, we worked with 2 counties, and that was somewhat easier, and that was back in the RHAP days, that we would do that, but now we're statewide, and so it's a little bit different. And it's a lot if you're trying to get geographic representation from the state. You're asking people basically to give up a day, to travel, and,
Sure.
now you can also do it remotely, and maybe we'll, look even more into those sorts of things, because that's becoming more and more commonplace.
Yeah, the Zoom technology is good. We've set it up, correct me, but we've set it up for quarterly meetings, 2 in person, 2 by Zoom. And we're trying to center one with the annual CTSI. In fact, we did meeting though, it's small and it's just starting and the attendance has not been robust.
Anybody on Zoom have any questions? Thank you, Dr. Hodder, for your presentation.
Thank you.